course, that you know, the further backwards you can look, the further forwards you can see. And I think many of us in policy realise that there's so little time to reflect on history, isn't there? And often doing is valued sometimes more than thinking. So it's fantastic to have some time for reflection. We often have a lot of churn of staff, loss of memory, coding and archiving, recording meetings, why we did things, often missed in the heat of the moment to get things done. This is a part of our fast world. So hopefully this evening we understand a little bit more about history, how it repeats, what we can learn from it, not just what happened and when, but what was the result, but also I think the way it was done, the way the department did things, how it was organised, what was the span of its remit, public health and social care, it used to be in its remit, as you know, and some of that's come back, the relationship with ministers and how to manage them. And for those of you, if you don't mind, a very quick advert. There's a spectacular book by the Chronicler-in-Chief of the Department of Health and indeed the Ministers of Health, which is by Nick Timmins, who's here tonight, that we published a few years ago, which is well worth reading. And also, I think, also learning about the sheer culture of the department and how it gets things done. And there's a few choice quotes in here. One from Frank Dobson, who said about the department, sorry, Chris, it tends to be staffed by people who produce a learned treatise on why the latest initiative has failed, rather than getting somebody who from the start making sure it works. Patricia Hewitt said there wasn't a strong Whitehall tradition there. And Andy Burnham, who was a bit kinder, who said friendly but very worldly wise was its staff. And some of the peculiarities of the department are obviously because it's unusual in that it used to have 3 grade 1s in old speak, PermSec, the NHS Chief Executive and the CMO, and that made for a particularly interesting creative tension that the department had. And my own view from working in there at that point over a couple of years, about 20 years ago, was certainly that there was very talented and competent people from different tribes. And also I concluded myself that I wasn't quite the right genotype to work in the department for 3 reasons. One was because there was a lot of talk about the Archers. The second was that a lot of people, rather too many people, liked cricket. And the third, believe it or not, quite a few people liked Cliff Richard. And even 20 years ago, that was still suspect. So anyway, I will stop. But just a couple of one other reason. The serious reason is looking forward. Obviously, we're in very unusual times politically. Understatement of the year. Climate, technology, economically challenging, dynamic environment, societal change, mass communications, fake truth, all this. Huge challenges, lots of moving parts. Health is at the centre of all those headwinds, isn't it? Department of Health has a key leadership role in helping to join the dots on some of this and push it forward, working across government, seeing the bigger picture. So I think that's really the challenge ahead, and I think the reflections of the past that I'm really interested in, and I'm sure you are in Chris saying, will help us try to navigate that future better. So many, many thanks, and I've said far more than enough, and over to my colleague here, Professor John Davies from the Director of the Strand Group. Thank you very much.
Well, a very big welcome to all of you, to King's and to the beautiful Bush House, and not only is it nice and airy, but the reception is really quite lovely, unless the rain. So the Strand Group exists to examine institutions of British government. And heretofore, we've done that. We've done it through teaching, training, research and defence, but heretofore it's been with number 10, with the Treasury, with the security and defence world. Thanks very much. But so this is a first for us with the Department for Health, and there's not much more for me to say than, this is the 38th Strand Group. It's the last one of our season, and we are delighted to welcome Sir Chris Wormald. Sir Chris.
Thank you very much. No, you can't clap before I start speaking. That must have been the clap for you, wasn't it? That's definitely not the clap for me. Right, I'm going to pace around while I do this, mainly to annoy the people with cameras. That's my main objective. I hate photographs of myself because I'm much shorter in photographs, much rounder and much balder than I in fact am. So I will pace around and attempt to avoid the cameras. Very, very grateful to KCL and the Strand Group for hosting this discussion. I think the work is completely invaluable. History really, really matters. I would say that. I'm a history undergraduate, as well as being PermSec of the Department of Health and Social Care, and as well as being the head of the policy profession. And frankly, I don't think we do enough of the looking back and asking ourselves, what does all this tell us? And the process of going through the creation of this speech, actually, for which I need to credit mainly Mr. Gavin Larner there, wave. Gavin has actually done most of the research that went into this. It is actually fascinating how much of what you find still resonates in today's debates. And that's largely what I'm going to be trying to be doing over the next 40 minutes or so. I am going to commit the undergraduate sin of doing a bit of narrative history of what's actually happened in the department, but also then try and pick out what are the themes running through that are A, interesting for our history, but also relevant to us today, and therefore very likely relevant to us going forward. And that's, of course, the real reason why we want to be doing these things, is what are the things we should be looking out for in the future, because they've been important to us in the past. So, starting with a bit of prehistory, we see this really as the antecedent of the Department of Health and Social Care. It's the Poor Law, basically. Basically, the English state's first intervention into the health of its subjects. It's really, really interesting. It is so old, actually. We were talking about this before we started. Many departments, the Treasury and the Foreign Office places, have much longer histories than we do. But if you look at it from the point of view of when did the state start caring about the health of its subjects, well, it really is 1601. And as many of you all know, poor laws requiring local support for paupers whose destitution was due to ill health. Very specific. It created, as you know, probably a patchy, parish-based system of provision, but was actually pretty stable. It goes on pretty much unchanged till about 1834. 233 years of basically the same system with the basic underpinning legislation. Whatever else we predict, I think we can probably conclude that we won't have another period where we have 233 years where we don't pass any legislation and we have basically the same system. What changed? Well, it was basically a social attitude thing that changed, and this again is very important for our history. The state's coming back to health issues really was about those great Victorian social reformers beginning to pick this up as an issue and pricking the public and the parliamentary consciousness about the state of the nation. Biggest change probably the 1834 Poor Law Amendment Act. Amongst other things, it set up Sir Edwin Chadwick as the first Poor Law Commissioner, which is, from what we've seen, that's basically the start of the health inspection, the Poor Law Commissioners. And you can basically draw a line between 1834 and the CQC. Now, actually, a very long history of the state moving on from we have to create some provision to a question of actually how good is it. Now, a very, very long history of that being part of what the state is for in health. And possibly even more interestingly, you see the beginnings in this period of what you would see as modern health policy, where the state is beginning to look at what is actually going on in society, and you begin to see a set of reactions that was not me, a set of reactions, both organisational and in policy terms, to what was happening. Most specific example, 1831, huge cholera outbreak driven by urbanisation and the health conditions that go through that, and an almost immediate reaction from Robert Peel passing a new Public Health Act and establishing the very first Board of Health, which is the first time we think that health as a word actually appeared in a title. It was supposed to be short-lived. It was overseeing about 1,200 local boards, and it was indeed stood down the following year. Really interesting idea from our perspective, that you set up a health board or a health department when you've got a health crisis, and then you shut it down again. Really interesting from our perspective. But what it certainly did was it did create the sort of the bug for health reform and state activity in health. The other thing Chadwick did, which I think is particularly interesting, he set up the General Registry Office to run the national census, the forerunner of the Office of Population Censuses and Surveys, that for a long time was part of the Department of Health. And indeed, my personal bit of history of this is my father was the last Registrar General of the Office of Population Censuses and Surveys before it became part of the Office of National Statistics. This is the beginning of big data, basically. And you saw, even from that period, some really quite incredible breakthroughs. The epidemiologist William Farr, who joined that organisation as a temporary worker originally, basically completely revolutionised health data by systematically recording the cause of death of every citizen. It's an incredible thing to do in the mid-19th century. You won't be able to read it, but basically, it does actually begin to characterise and then add up to what did people actually die of. And if you think of the change between not knowing what your population was actually dying of, and then knowing to this sort of level of detail. This is from London, where you can count, 43 cases of syphilis, 189 cases of syphilis over 3 years, and then you can track it. All began in the middle of the 18th centuries. And then very famously, it allowed Farr eventually to prove that cholera was waterborne, not airborne, from a study in a single outbreak in Broad Street in Soho in 1854. So first example, or certainly the first example in England, of actually being able to diagnose disease by looking at the base data. Well, think of the reflections of that into what we do today, which I'll come back later. Slightly prior to that, the Victorians had already, as a part of their newfound power and obsession with data, founded the General Board of Health, which was established in 1848. And from then, the history of a health department is pretty much constant. So having had that break from the previous Board of Health from 1848, we can begin to try and basically draw a line to the current day. And unfortunately, some really quite recognisable patterns begin to emerge. At the time, the board was widely regarded as being autocratic towards local authorities with whom it worked. That, of course, never happens with government departments today. It completely failed to appoint a chief medical officer. So you had a health board with no actual medical expertise for 7 years of its existence. And it was therefore shut down in 1858 after 10 years, which is the first of many national health reorganisations that we have had in the period since. We think 1858 is basically the first one where we thought, let's reorganise how the states worked. Now, what actually happened at that point, the medical functions all went to the Privy Council. Can you imagine that? It's an extraordinary thing to do at the time. But we also, at that point, that's when the General Medical Council was created, was in that set of reforms in 1858. It continues to the present day. So as you'll see in this story, we've already had some health reorganisation, we've already had the setting up of an inspection system, and we've already had a General Medical Council, and it's only 1854. Public health functions went to the Home Office. Some civil servants in the room not really being able to imagine that one happening again. Resulting in what one commentator called an incoherence fast approaching chaos. And there was then a couple of decades of basically laissez-faire. Growing evidence of abysmal public health and sanitation. Finally, basically stirred Gladstone into action, and in 1871 he established what was called a local government board. Now the functions of this one, 1871, are really, really interesting, and I'll come over. It covered births and deaths registration, all those Office of Population and Censuses stuff, public health, local government, drainage and sanitation, town improvements, artisans and labourers' dwellings, and highways, all in the same organisation. Now, I'm going to come back to those functions things, and you mentioned them in their introduction. Some of those have really interesting lessons for us today. But anyway, so you have this very, very all-encompassing board, and which does successfully last for about 50 years. And achieved an enormous amount. In particular, its crowning achievement was the sanitation and water supply system. That is the board that built all those Victorian sewers and water systems, which we are still upgrading, replacing at vast expense slowly today. But that all dates from that period of history. It had a lot of challenges. It was widely regarded as having lost touch with local government, again, despite its name. And by the turn of the century, basically, the government believed it had really quite a lot of problems in health, particularly the pretty dismal state of British Army recruits for the Second Boer War, and general concern about the health of the nation. And you see this story of this local government board generally losing power, completely sidestepped when national insurance for health was introduced by Lloyd George in 1911. So that was the situation going into the First World War, that you had this story of the state becoming more and more interested in health. You can see it sort of slightly struggling with what's the right organisation for exhibiting that function, but actually a lot of what makes up the current department and our current portfolio already having its antecedents. You know, I've mentioned a whole series of them. And this, of course, then plays into the state having a very, very hard look at itself as a result of the First World War, and then crucially for us, the Spanish flu in 1919. You have these two big health crises, people coming back from the wars with a whole range of conditions, and then, the last great pandemic we have faced. Well, it won't be the last, but it's the most recent. And this call for a different type of national body to do this. And so the local government board was shut down. Its parting shot, I love its parting shot, was to recommend porridge and frequent toothbrushing as the answer to the Spanish flu. That bit we definitely have dropped from our policy portfolio. We don't do that anymore, but it's a sort of suitable note for the end of that organisation. So that's what gets us to the formation of the department. It's that range of things interacting, that policy interest, and then this sense of we haven't got the right sort of organisation. So you have the new Department of Health. established by an Act of Parliament almost exactly 100 years ago. And again, its actual range of functions, really interesting. It took on the Poor Law, which still existed. It took on the health insurance scheme. It took on the responsibility for health of mothers and young children, and then a whole series of other functions: housing, town planning, waters, sewers, all in an organisation titled the Ministry of Health. Really interesting and different lens on the world to the one we see now, that all those issues were seen first from a health perspective. As it were, that was the reason for the state being interested in those things, and therefore put in a Ministry of Health. So I'll come back to this later, but one of the big points of this is when you look at who does the Department of Health have to work with now in the pursuit of public health, it is the people with exactly that set of responsibilities. We are in long conversations, as you know, with DEFRA about questions around air quality and about all those types of issues. A lot of discussions we have with what is now MHCLG about housing. And actually, interestingly, as the focus has shifted from the provision of health and how good are our hospitals and etc., to how do we promote wider health, we come back to quite a similar list to the origins of the department there. This is not, by the way, a bid to create a new super department. I have more than enough to do. But that question, which we sometimes think is a modern question of how do we join up, well, actually, people were thinking about that 100 years ago, and of course, rather before all that. First permanent secretary of the department was this gentleman, Sir Robert Morant. He'd previously been permanent secretary at the Board of Education, which is great for me because I was previously permanent secretary at the Department of Education. Although what I can't claim, he did a stint also as tutor of the Crown Prince of Siam, which I haven't quite managed at any point in my career. The other really interesting thing about the creation of the department was the Minister for Health, then Christopher Addison, was also designated Registrar General. And that thing, even 100 years ago, of seeing health and data as being the same issue, again, really interesting from 100 years perspective. We sometimes think of that as a new thing, but the creators of the department had exactly the same thought. Now, there isn't actually very much written about the early days of the department, so for the historians in the audience, I can challenge you to do some proper research. But as far as we can tell from our archives, the ministry launched almost immediately into campaigning for a unified health service, and it basically spent 29 years doing that. So throughout the 30s, having created a nationally accountable thing for the first time, with ministers and a department, interestingly, its first question was, how do we unify the system? Really interesting for those of you who are interested in organisational theory about how the structure of an organisation begins to drive what policies does that organisation pursue. We should definitely think about that as we go forward. It did quite a lot of other things as well. It did spend quite a lot of time on slum clearances and food and drug safety, as well as doing what you would imagine it was doing, of supporting the then voluntary hospitals through that. One other very spectacular thing that it did was in 1938, the minister persuaded Lord Anderson of Shelter fame to transfer responsibility of wartime evacuation from the Home Office to the Ministry of Health, which was basically because of its responsibilities for children and housing. So that whole wartime evacuation program is actually run from the department. Now, one of the things I really take pride in the current department, and indeed the NHS, is how it responds in an emergency. I think pretty much whoever you are, when you look at what the NHS and the wider health system can do in an emergency, be it Ebola or London Bridge or Salisbury and all these other things we get thrown at us, I think pretty much everyone is impressed by that. But even by those standards, Operation Pied Piper is really quite a feat. Not only did the department successfully create the conditions with an extremely sustained communication effort in which parents would allow their children to be removed to places they did not know, to live with people they did not know, it then actually did the implementation of it, which saw 3 million properly labelled children moved across the country out of the range of the Luftwaffe. Is actually an incredible feat, not only of communication and of policy, but then of administration to make all that work. So for those of you, well, a number of you from the departments, that's your threshold for delivery, okay? That's the level we're now looking for, having done our research. You're going to regret coming now. You can ask me nasty questions later. Now, post-war, of course, and this is obviously much better recorded elsewhere, setting up of the NHS, and that becomes the defining issue of the department. And again, from an organisational design perspective, really interesting. All those other things that are not the provision of health then go off to other departments. That's when the Ministry of Housing and Local Government is set up, which took on obviously housing responsibilities and also a lot of those standards of life type responsibilities. And the department, its history from then on is pretty much dominated by the provision of health as opposed to those questions of the drivers of health that have been put together in the first place. I'll come back to that later. The actual creation of the NHS, I'm not going to talk about this in great detail because obviously it's been very well recorded, but it is a really quite remarkable piece of policy making in a department where you really see the sort of political vision and leadership provided by ministers and politicians at the time, linked with what the civil service did. And slightly legendarily, the 1944 white paper that developed the NHS was basically written with a single pen by Sir John Horton, who was a civil servant in the department, who later became permanent secretary, and pretty much every word of what was in the white paper was scribed by him. Another lesson for the civil servants in the room. Whenever you're thinking of cutting and pasting something into a white paper, no, you can actually write it all yourself. So the interesting thing from the department's point of view, obviously there's a lot in the history of the NHS that we don't have time for today, but the interesting thing from the department's point of view is that interaction of health expertise, policy making, ministers, politics and public mood that came together for this incredible piece of policy making that, of course, one way or another still dominates our responsibilities today. Now, as I say, at this point, when we took on that stewardship role of the NHS, we shared most of the rest of our responsibilities for housing and all those things. One of the things we did do, however, the National Assistance Act of 1948, which finally repealed the poor laws. And what it replaced them with was a local government responsibility for the care of older people and the requirement for care homes to be registered. So it was actually the unwinding of the poor law that created our current position with social care in 1948, actually as a part of all those changes, which, as we know, the nation has been wrestling with one way or another pretty much from that point to current day. Same period also brought a much more assertive and comprehensive approach to immunization, which over the decades has eradicated diphtheria and polio, and as long as the anti-vax campaigners don't win, also measles, mumps, rubella, and also when the long march of antibiotics began, which, as my dear colleague, the Chief Medical Officer, points out, we're currently at risk of reversing. Now, these are interesting things as they're in their own right, but they're also a really interesting example of the interaction that we still deal with today, the dynamic of the department, where what we are dealing with is technology, public opinion, and administration and law slammed together. And actually, when you look at the history of health policy, the dynamic of those three things is very frequently the driver of everything. And that question of how technology and policy interact, as it did in this case very successfully, I think is one of our grand policy dilemmas. Also in the 1950s, and again this flowed very much out of the data analysis done by the department and the department's statisticians, who were looking in particular at the effects of newly introduced psychiatric drugs. You began to see the early movements towards community care and reducing admissions and speeding up discharge for severe mental illness, and what was at the time a really bold new policy drive to close down all the old water tower asylums and the culture that they enshrined. 1950s. Now, of course, that debate is still going on. Now, again, you can see this really interesting thread between data analysis in a department into a public debate that causes some real-world change, but is never really finished. So again, as a sort of lesson in how we do policy, again, a really interesting story of how it moves on. And of course, an area where, as we all know, we have considerable more to do before we are where we really need to be. Get to the end of the 60s, and we have some more organisational change because we haven't had any of that for a bit. And we create this really rather remarkable department, the Department of Health and Social Security. A huge, unwieldy sort of behemoth of a department. And again, even this being quite recent history, very, very difficult to imagine putting those functions together again. And I think probably to the relief of everyone, I think in particular secretaries of state, actually, because if you think about trying to be accountable for the whole benefit system and the whole health system, it was all demerged again in 1988. Now, lots more you could say about more recent history. Most of it has been written about a lot, so I'm not going to cover that in considerable detail. But there are three things from more recent history that I do want to focus on. Now, children. We stopped being responsible for children when it moved over to my next department at DFE, but the department did pass the Children's Act in 1989. Again, a very sort of landmark piece of legislation. It was, as many of you will know, the first act that put very firmly at the centre of children's legislation the needs of the child, as opposed to how the system worked. And I know a lot of the people who worked on that are extremely proud. Second thing, you can't, where am I? You can't ignore in our history, and shouldn't, is a highly, highly evidence-based response to the HIV/AIDS epidemic. Many of you will remember this advertising campaign at the time, seen as an incredibly brave move by ministers in what, from our perspective, would look like a very socially conservative world indeed, a very brave set of decisions by ministers based on a huge amount of analysis done by the department that is seen all over the world as being the best response. And again, that thing of the department is at its absolute best when it's done the evidence, and then you get that political leadership, and you can really do something that is completely world-leading, not necessarily popular, but completely world-leading. I think that is a big lesson. And the third one I'd like to point out, and again, it's an area where, say, whatever you think of us, the stats show we're world-leading. What the department has done to reduce smoking rates. And, interesting from the current perspective, tackling an enormous amount of fake news that was around at the time. So if people, and many people in the room will remember those debates between the people who alleged that there was no link between smoking and ill health, finally defeated by the facts, and we've seen those changes to smoking rates, where we have now some of the lowest anywhere in Europe, all flowing out of that ability of the department, led by its ministers, to take on public opinion when it is right to do so. Now, I've spent quite a lot of time congratulating the department, and of course it's our birthday, so we're allowed. But we do have to reflect for at least a part that also over this period, really quite a lot has gone wrong. We should say that both for honesty, but also because it's very, very important to learn the lessons. You will know the list, but thalidomide, the Bristol Paediatric Heart Surgery, Harold Shipman, mid-staffs, Jimmy Savile, Morecambe Bay, Gosport infected blood. You could probably create a longer list. For me, as I say, very important that we tell the whole history, and many of those things are not our proudest moments, clearly, but also, more importantly, a sort of painful reminder of the importance of actually the moral imperative of public service, and that going with that moral imperative is never be complacent, never ever, just because you have a system that is there to do good and is almost exclusively filled with people who want to do good. Nevertheless, we have to be ever vigilant, and we have to have those checks and balances. We have to have that scrutiny and that transparency. We have to have those what look at the time annoying questions, be they from parliamentarians or from journalists or from whistleblowers or from whoever, that actually shine a light on a system that's there to do good. What are the things that do bad? And there's a very important lesson for us all in our history in just how important all that scrutiny from the outside, as well as what we put in the inside, is for us being the system we want. And we can't learn that lesson often enough. A few short words about politicians. We've got one of my ministers at the back, so I have to be careful what I say at this point. Now, I've focused on the department and the work of civil servants, and that's what we're here to talk about. There's obviously a lot you can read about the political leadership. I was going to quote Nick's book as well, but I won't, because you have already. Clearly, you can name the hugely influential politicians who have led the department. And if you were writing the story of health, a lot of them would be much more prominent than what I am talking about today. What's interesting from our perspective is when you look at the relations between civil servants and ministers, what you do see is this very, very steady stream of advice, very firmly rooted in the science and the statistics of what we do. And I've quoted some of the examples already, but again, we are at our best when we are providing ministers with that really rigorous evidence-based advice. And that equips ministers to make these incredibly tough, frequently moral, sometimes political, but very frequently moral calls that you have to make as a health minister if you are going to do your job and do best by citizens. And it's that interaction of when we're at our best, of what does the science tell us and what does the data tell us and what does the evidence tell us, and then the moral leadership of ministers who I say take these things that are not technocratic decisions. They're not, they flow straight out of the evidence. They are decisions that tell you something about what you mean, what you think about society and what type of society you think you are. Now, that brings the end of the sort of narrative bit of what I'm going to say. What I'm now going to do is just pull out some themes. You'll notice I've stopped about 20 years ago, which means I'm going to avoid all current controversies in health. Cunning, huh? I could have gone on to pick out many of the same themes from what we have done recently, but instead we will look at, so what themes can we draw from what? The first, the most obvious thing is the world has really changed. I'm not expecting people to read all these numbers, but basically this compares 1919 to 2019. We had a lot of fun doing this. This bit is actually, I think, the most interesting bit. When you look at, death rates from different things, all those basically communicable diseases on the left-hand side that in 1919, that's what your health system was about. This chart over here shows what was the main cause of death of people of particular ages. You will see it's largely infection. So we designed a health system and a ministry and a health service basically to deal with the problem of infection. You look at those numbers today, they are of course tiny by comparison. We still have more of a TB problem than we probably should have. But you've essentially, if you look at the original mission, what was the department for? What was the health system for? It basically solved the problem it was originally aimed at. And what we now have is a whole series of different challenges, which are, and I'll say a bit more about this in a bit, about what happens when you are really successful. Actually, what happens when you achieve your original mission, and then how do you adapt? We spend an enormous amount of money, really quite colossal amounts of money doing it, but nevertheless, this really quite remarkable achievement, I mean, it's true across Western health, of basically having dealt with what we set up our systems for. So, no, I've gone one too far. Some themes. First one, and I say I've mentioned almost all of these as we've gone along, so I will just come in. Big theme about data, evidence, and expertise. You can see right back to the pre-history of the department and then the department itself, how this is about how you bring data and evidence to public policy, whether it's about smoking, whether it's about HIV, all those things. And the challenge for the department in all this is, as that evidence base expands, as it gets to the point where actually you can't hold it in a department, the department is not the depository of all data and all analysis. How do you make good policy then? That's our challenge. Actually, different from what many departments face, do we have the right data sources? We almost have too many. You can analyse almost anything in health, and that will get more and more. And clearly, your model of policy making will not be 1,600 people looking at all that and taking decisions or advising people. Quite clearly, in that sort of world, you need a much more open style of policy making going forward, where that data, that information is analysed everywhere, and the job of the department becomes to how do you suck that from the outside world, as it were. How do we become, as it were, the people who can bring together analysis as opposed to just the people who do analysis. So I think there's a very, very big theme around all that. Clearly, the department will always have to have its expertise, symbolised, by the chief medical officer. We've had incredible chief medical officers, culminating in Sally Davis, who just appointed Chris Whitty as the new one. And obviously, that will always be a key part of the evidence synthesis or whatever. But I think that whole area, important from our start, is going to go on being different and important. Secondly, I'm still on the wrong slide. Secondly, technology. And I've mentioned a couple of times how that interaction between technological development and how we organise ourselves and how we make policy very, very much shapes not just the policies we do, but the type of organisation we are. And again, look at the effect that digital will have just on the organisation of the department. We've just set up NHSX, AI, genomics. There were all sorts of these game-changing technologies. Now, that is, as I hope I've demonstrated, not new. We've seen throughout our history that actually we've had a series of game-changing technologies, and the way we need to think about that is not how do we respond to this technology, but how do we respond to technological advancement that we do not know exists yet. At its most blunt, we're going to be training doctors right now to use in 20 years' time technologies no one has even contemplated. So how do you train a doctor? How do you make policy to train somebody to use it? What skills are we teaching people, and what policies are we setting to do that? So I think that technology element will be huge for us. And as I say, also changes not just what policy you make, but how you make it. That classic policy-making thing we do of here's a submission, then there's a green paper, then there's a white paper, then there's a legislation, and then implementation. That feels, we still do it occasionally, it's the right answer for something, but it feels really quite old-fashioned in a environment where actually you can iterate things in real time with the public. That thing of here's our consultation period, it lasts 3 months. I think that's one of the things future generations will laugh at us about. They used to have consultation periods. What's one of those? So I think that whole area of technology and policy. I now will go on to this. Diversity for the department. Some really interesting stories here, drawn from members of staff via Gavin who were there at the time, and some interesting challenges for us. As I said, the idea of a DHSS now, really rather curious, but it shaped a completely different type of department. If it had a DHSS office in every area and civil servants who worked in every area of the country, and you could work your way up from joining as an administrative assistant in somewhere not London, and you could work your way all the way to the top, actually you get a very different flavour of department from that. So how do we get that diversity when we don't have that, as it were, pool that feeds into us? And then the second story around the same theme. When our predecessors set up the first AIDS unit in the department, it brought in a lot of people to work on it, including quite a lot of people, and it's been described to me by people who were there at the time, who were the first time really proud of their sexuality. And they come to the department to work on that issue. And that drove a cultural change. and you see the antecedents of bring your whole self to work, there to solve a policy problem and ensure that everything was rooted in like real life experience, because obviously if you're going to communicate, you have to understand. A lesson for us from the 1980s that we maybe haven't always seized today, and as we make the next step forward on diversity and diversity of thought that we all want to make, actually that from a crisis, a very interesting lesson. And then, I'm probably running out of time. How are we doing? I'm all right. Done technology. Third theme, demand and demography. This too has completely shaped us as a department and will continue to do so. This one just charts life expectancy, which is a very familiar chart, but actually rather more interestingly, just how dramatically our demography is changing and how that drives demand in the system. This is the quid pro quo of us basically achieving our original purpose. People are not dying at these ages of infections. All our challenges at the moment, all our financial challenges, all our challenges about social care, all our challenges about number of hospital beds and community care, basically underlyingly driven by the fact that what we did worked. It's a really, really interesting lesson for public policy, both in health and beyond. And one of the things we very, very rarely do, what are the consequences of your policy working? We always ask ourselves, what are the consequences of it not working? But what are the consequences of it working? So this is both our biggest challenge, the whole of Western health's biggest challenge, but also quite clearly the biggest triumph of Western health. Though within it, and many of you will be familiar with this chart, within it some really quite sobering things. Basically what this chart does is it shows disability-free life expectancy versus life expectancy by income decile. Now, quite clearly, life expectancy does go up as you're richer. The really, really alarming thing for us, and this will be a challenge for policymakers for years to come, is healthy life expectancy. The line is much sharper. So it's not just people live longer than they're richer. That narrowing gap, really interesting, and asks us a really interesting question about what is a health system and health policy for. Is it for length of life, which has largely been people's objective for the last 40 years, or is it actually that healthy life now? Is that more of a challenge for us? And should that be more of our policy? How long do people live healthily? Than the question we've normally asked ourselves about how long do people live? Do we actually need to change that very fundamental question of what is policy for? Again, a moral question, not for an administrator to answer it, and the data won't tell you, but as a question for society to debate as a moral question. I think that is a really interesting lesson for all of us. I'll skip over that. And finally, to come back to the department, really interesting questions that flow out of all this history as to what is a department actually for. The story I've basically told you, the sort of summary version goes, it started as a strategy thing that was largely about joining up different issues. How do we join up health and water and etc. Then has a long period when it actually runs the NHS, and it's a delivery systems thing. And then, interestingly, it's gone back as we've made the NHS responsible for its own responsibilities. It's gone back to being much more like it was in 1919, actually. It's a strategy house that's setting direction and spends quite a lot of its time on the how do we join up with other services question, while those questions of how do we commission services, provide primary care, provide secondary care, are dealt with by the Simon Stevenses of this world, and that's a separate operation. Actually, the departments slightly come full circle. Now, I don't think anyone ever chose those changes and routes. It sort of evolved like that. And I'll say, this is the pleasure of looking back over 100 years, is it causes you to ask these questions. Actually, what is the right role for the very centre of government in this? We've taken our choice at the moment that actually it is that setting direction and that moral leadership and that part that goes around the political process, and that's different from running services. But again, a question that I'm sure we'll debate. My final point, and then we will open this up for some questions for the future. I think we will have a great future. I believe that because when you look at a department, actually, what is it? It's a load of human beings in a building with some technology and some systems. And what makes me both proud and confident about our future is throughout this story of the department and including its current staff, we just have wonderful people. And throughout this whole story, all those successes, that's what it's really down to, both in the health service and in the department. Wonderful people trying to make the world better. We still have that. I'm incredibly proud of it, and hopefully it will see us through the next 100 years, as it has through the last. And
Thank you. Okay, we've got about 15 minutes for questions. Can I see hands? Can you tell me your affiliation? Can you keep your questions short? Can you wait for the microphone? Who's first, please? Down the front right here, as far away as possible. Martin, here we are.
Hello, Carolyn Quinn from BBC, here out of interest. Radio 4. Can I cheekily ask two questions? The first one, so 1919, it was a British system, wasn't it? When the department was set up, it was covering the whole of Britain. So in terms of devolved systems, presumably tackling health problems has the same treatment wherever you live, but is it more just a case of how much money is devoted to certain projects in certain parts of the UK, or are there different priorities now? And the second one is the cheeky one, which is, does it help or hinder having ministers who've been in the health service, who've been doctors or nurses or worked in the health service, or is it easier if they have never been there?
I'm not sure I'm going to answer the second one. The first one, I think in policy we sometimes make the mistake of assuming there is a single answer to that question, as opposed to what's the nature of the problem and therefore what is the right level to deal with it. So it's an area where we tend to do that sort of pendulum thing. We must devolve everything, or we must nationalise everything, get economies of scale, and etc. I think there is a more nuanced policy debate to be had that goes, what is the nature of the issue, and therefore what is the right layer to deal with it. So if you take something like, I'll take some of you describe, so antimicrobial resistance clearly has to be done at international level. If we do not all move, you won't solve the problem, and it has to be dealt at that sort of level. An awful lot of public health is actually driven by geographical boundaries, clearly, as opposed to where do we draw a line on the map. And then we have quite a lot of issues, more than we think we have, where it really is different in different places, just because the demography, the economy, and the culture is different. Right down to the example my chief scientist, about to be chief medical officer, Chris Whitty, always uses is most of our services are based in the centre of big cities, whereas increasingly the country is dividing itself where younger people live in big cities and older people do not. Of course, the biggest users of those services are older people, so why are all our facilities in the centre of big cities? Answer, that's because that's where they used to be the biggest health problems, not where they are now. So certainly in the patterns of provision, if not in the actual clinical treatment, there are real differences between places, and therefore the more you can devolve, the better, quite clearly. For me. In terms of classic devolution, I do think we've actually created a really interesting thing, because of course we've created some natural experiments. Now, that wasn't why it was done, but actually when you look at the capacity of, in this case, not one of our bits of devolution, but we would not have got where we were on smoking if the Republic of Ireland had not. We wouldn't be where we are on plastic bag taxes if Wales had not. Everyone is looking with interest at what Scotland is doing around alcohol. And that benefit of devolution, of actually the creation of natural experiments where you can try something out and see if it works, which of course you don't have to have a formal piece of devolution to do. That way of making policy, as opposed to let's try and move the whole system from A to B, I think is a much more powerful way of making policy and seeing what works. And I think we ought to see the devolution question through that lens as well. What can I say about your second question? I don't think I've actually had any ministers who've been active in the health service while I've been there, so I'm not sure I can answer. But I think my general answer is I don't think it really matters. As I said throughout, I thought when you've seen where it works, where it's worked best in health policy, you've had ministers who are providing that very clear, not just political but moral lead on behalf of the electorate, backed by hopefully technical excellence of what they're given by the department. And I think you can do that regardless of what your professional background is. So that's when I think the department works at its best, and I don't think it's dependent on the professional background of who happens to be a minister. I think.
Who's next, please? Let's have a look. There, please. Yep.
Hi, Christine Maguire, Department of Health and Social Care. So my question is about probably quite specific, although you touched upon it in your question about technology. We've seen the rise of social media and some interesting public debates about the underpinning science and medicine. Do you think this is something new in policy making, or is there something we can look back to and learn? Is there something we need to do about explaining more about medicine and risk and benefits?
It's clearly new in terms of the method of transmission. As I said at some points in my speech, actually some of the arguments where you have what turned out to be true science and science that was slightly less true playing out in public policy, around smoking and some of those other issues. Of course, that's all happened for a long time. I don't think that's the same as saying the current situation is just like it's always been. I don't think it is, just because clearly social media has, for good and bad, created an entirely different type of engagement, both between individuals and between individuals and the state. So I do think it is different, even though you can see some of the phenomenons going backwards in time. How we respond as policymakers, I think basically the era where you could stand up and say, we nationally have looked at this and our expertise tells us, and expect everyone to believe us, I think that is gone in most areas. And of course, in a lot of ways, it's a positive thing that that's gone. That very, very hierarchical relationship between the state and the individual, of course, has a lot of downsides to it. And some of the things of which we are not proud, I quoted, you could see those phenomena in. It clearly has some downsides to it too. And in terms of how we want to respond, I think the question of how we use local expertise becomes hugely, hugely important to us. So when you look at the Mori polling, you know, individual doctors and nurses, hugely trusted for very good reason. So that question, if we want to persuade the public, how do we persuade the public trust? How do we persuade that doctor and that nurse, you know, who is not on the television, but you meet them because you've gone to the GP surgery, or you're in the hospital waiting room and you're talking, or etc. In future, I think that type of how we transmit our message and have the debate, where we say, if we cannot convince the people who the public trust to have those conversations locally, well, why should anyone else believe us, as it were? So I think it is that mindset we have to be in that new sort of world. And I'll say it's not necessarily a bad thing. You know, it makes, as civil servants, it makes our jobs much more difficult than what we did previously. You know, here's a nice press notice that explains the answer. It's much more difficult. But in a way, it's a sort of rather more healthy process of how we should do public debate, potentially.
Thank you. One there and one over there. So we've only just got a few minutes, but we'll get through. First one down the front here, please, Mark.
Matt Ross of Global Government Forum. You talked about the need to work across departmental boundaries with your colleagues in this country. Is there also a growing need to work internationally with your peers in other countries? Because there's obviously increasing range of transmission and disease and the like, and probably a lot of countries experiencing the same set of challenges.
Yeah, I'll answer that in 2 points. I think on some issues, it is, of course, where health is just indescribably further ahead than other sectors. You see medical advances, you know, that spread around the world through, you know, professional links without governments doing anything. You watch how, look at how keyhole surgeries spread. It was never a government initiative or whatever. It was people internationally talking to each other at that conference or reading that thing in the Lancet or the BMJ. And for on the clinical side, we have this incredible knowledge transfer and transmission system that any sector would be proud of. We do much less on that. How do we tackle some of these bigger challenges and those sorts of organisational questions, actually? So we don't have an organisational debate amongst countries, anything like as well as our clinical colleagues talk about the clinical bit. And when I've gone around the world, you know, you do find, you know, most countries are basically facing the same sorts of challenges. So, I mean, those demand curves I put up, that's true of pretty much any Western country. That sort of thing we're much worse at talking about. So I think we've got some really good building blocks, but we do have to sort of broaden the conversation internationally.
A last question over here, please.
Thank you. Absolutely brilliant talk. Very interesting. Jennifer Rubin here. I'm a professor of public policy at King's as one of my roles. I just wanted to ask, really interesting going back to 1601 and the Poor Laws. And there it was very much about the health determinants of a societal challenge in terms of destitution and pauperism. And it feels like in the trajectory that you then traced, we've moved back to a situation, if you look at the graphs that you put up about, you know, life expectancy going up, but healthy life expectancy being a particular challenge, especially for, you know, poorer groups and caused by environmental and social and wider challenges like that. Do we need to swing back, in your view, to thinking about the societal drivers of health instead of the health drivers of societal challenges? And if so, what would be the DHSC's role in that?
Well, I think the basic answer is yes. And as I say, when you look at the public debate now, actually those questions about things like air quality are there in the public debate in a way that they just weren't before. You know, we have, for quite a long time, we have largely debated how do you, the supply of health as opposed to what is creating the demand for health services. I think that is genuinely a more balanced debate now. It's not as balanced in terms of activity, quite clearly, so there's a long way to go. But in terms of how the public debate has moved on, then that's definitely changed. And that thing about the departmental role I talked about at the end, I think that role of the department, as well as its sort of straight health responsibilities, its ability to join up across sectors is something that a department can bring to the party that it's quite difficult for other people to. So I do think that role of the department as being the people who are going and having those conversations with DEFRA or with Transport or with CLG is something that we have at times underplayed. And as I say, because we are not now the same thing as the NHS, that is actually a role that is opened up for us. That was not there under some previous organisational structures, but as I say, way back, yes, it was. So I think I'd see it like that.
Well, I think that draws us to an end. Thank you, all of you, for coming. Do join us for a drink and join me in thanking Sir Chris for what was, I think, quite a fascinating lecture. Thank you.
Thank you.